really warm welcome. My name's Linda Wensley. While I'm employed by the Canterbury District Health Board, my role here tonight is actually as part of the Canterbury Clinical Network Alliance. I've been involved in this enhanced capitation project for around 2 years, and I know there's been some people thinking and talking about it a long time before that. My role has been as facilitator and support for the flexible funding for SLA, and underneath that the enhanced capitation work group. It's been a fantastic project to be involved in. There's some great input from a range of people into the work. And it's equally exciting to have now got to this stage where we can start to talk about it with the general practice teams and hear from general practice teams the types of things they're thinking and how it could work, and other aspects that they bring to the table. So it is fantastic to get to this stage. It is the last of our 5 meetings, but I'm sure there'll be lots of ongoing discussion. So without more ado, I'll hand over to Dr. Martin Sears, who's one of the 3 clinical leads that's been working on this project, to talk through the presentation.
G'day, and thanks all for coming and listening to the presentation. As Linda says, this has actually been 3 or 4 years of sort of planning and thinking, and really the journey has been one of looking at progressing that whole process we went into when we went from fee-for-service into capitation, and then of course we've had the extra money that was put into PHOs through SAA, Care Plus, Health Promotion and others, and having a look at that in a more flexible way. So around the country that's been used in all sorts of different ways, and in Canterbury I think we've got some innovation, but there's a number of us who got together a few years ago trying to say, look, let's continue on that journey of moving away from a fee-for-service paradigm and think about getting the best possible value out of the funding that's available. So, So what I'm going to do is quickly run through what the program's all about, and try and explain some of the ins and the outs and why it works the way it does and so on. So first of all, it's about patient care. So what we're trying to do is enable better coordinated care. There's pretty good evidence out there that if you take people with complex health, social and mental health needs and coordinate their care, you get better outcomes. And so that's really what the Care Plus program was all about. Now, how that got interpreted 7 or 8 years ago was in those things that we all know and deal with every day, which is 2 or more chronic conditions and 6 or more visits and all of those other sort of entry criteria, but they were just were markers of what might be people who needed coordinated care. In actual fact, in thinking about this program, we actually think that we don't want practice teams to have to be jumping through hoops to actually say, no, this person can be and this person can't be. We want there to be much more flexible use, because we think that general practice teams are very good at directing financial resource where it needs to go. So what we're trying to do is give you much more flexibility and hopefully more funds as well. So what will it do for general practice? Well, the first thing is you'll get some certainty of funding. So unlike currently where you draw stuff down on a patient-by-patient basis, we're going to work out what we think your population needs, tell you what it's going to be, and then you're going to get that amount. We'd like you to do a whole lot of work and do really cool stuff with that funding. We'll come to that in a minute. And the second thing is reducing the administrative burden that's associated. So the 3 PHOs in Canterbury do all slightly different things about the way we use Care Plus, but we all know what the administrative burden is of hiring a health card, which drives many of us mental. And Care Plus, still you have to draw down on a dollar-by-dollar basis. So this program is basically about making more funds available, and I'll explain where the money comes from in just a minute. Distributing Care Plus monthly in an allocated amount directly to the practices, and replacing host health funding with additional Care Plus. So that's the tricky bit, which I'll try and explain. From a coalface point of view, what we're doing is we're giving you high flexibility, the opportunity to innovate. It's a high trust environment, and the opportunity to learn from each other. So those of you who've been around for a while, and the docs I see in the room have been, you can remember that when we started the acute demand program, we kind of said, look, we know that well-resourced general practice teams can do way more for people who've got an acute illness than what we currently do, and the funding was the problem. Funding and support services were the problem. And so we didn't know what we needed to put into place, but we knew that if we got the right things, that the acute demand program would be a success. And that's been proven. We're now running, I think, one of the most successful acute demand programs in the country, possibly in the world. And really what we did back then is we said, we trust you guys, go out and spend up to $300 and tell us what you're doing. And we're kind of doing a similar thing with this program, as we're saying the goal is reducing unplanned care and improving coordination of care for your complex patients. Go out and do innovative things and tell us what you're doing. And the kind of the rules are off. You know, you can use those in a bunch of, you can use that funds and resource in a bunch of different ways, and the system is going to want to try and learn from what you're doing. So people have asked us, well, what can we do with the money? And we kind of hesitated because we don't want to tell you what to do, but we put this up because people still say to us, well, what do you want us to do? So look, this is stuff that we don't necessarily want you to do, but you could do if you want to. So you can employ staff to do coordinated care. So there's a number of practices that have care coordinators, and they find that makes quite a big difference for their present use of unplanned care services like ED and out-of-hours services. Supporting nursing staff to carry on that journey of increased nurse-led service delivery, multidisciplinary team approaches, so thinking outside the square of our standard 15-minute patient makes the appointment kind of system that many of us still work in. Extended consultations, you can subsidise some of the care, you can use innovative ways, and engaging with non-traditional services as well. So, and the reason we're having these meetings now is to give you 3 or 4 months so that you can start doing the thinking amongst your teams about how you might use some of this flexible funding. So, how's it going to be allocated? It's a monthly based allocation, as I said, so it'll arrive very much the same way as your capitated funding does. What we've done, sorry, let's come back a step. The way that the ministry funds the region is based on a population health funding formula which takes into account deprivation, ethnicity, age as parameters of need. And I'll show you a graph in a minute. And that comes in a very lumpy and not particularly targeted way. So the group of us have been working on this, decided, well, and for example, you get exactly the same number of dollars for a 65-year-old as you do for an 85, as you do for a 95-year-old under the ministry formula, and we think that's pretty dumb. So we went and had a look at how you have been using all those services for the last few years. And as you might expect, there is an increase in 65-year-olds, but it gets higher to 75 and higher to 85. And so what we've done is we've called that the Canterbury profile, which is just exactly what you have all been using these funds for, and we've applied that to each of our practice populations. So we think that that more represents complexity of need, because it's basically what you guys have been doing for the last number of years. The bottom point there is that it does then weight towards the older population, but that seems logical to us in that, in fact, a lot of capitation funding tends to be weighted towards youth, or babies in particular, but youth as well. So the blue line is the ministry's distribution of the funding. As you see, it does just jumps based on age, and the red line is actually what we do in Canterbury, the whole of Canterbury use of Care Plus funding. Now, this is where I try and explain how you get more money into the system. So essentially, if the system works the way we believe it will, there's an extra between $800,000 and $1 million come into Canterbury primary care provision of service. So, what currently happens is the DHB gets funded on a population-based formula. And for every high user health card that we fill out, they deduct that money that they pay to us from Canterbury's population funding. And then, when they work out Care Plus, they deduct that number again from the Care Plus bucket. So the DHB loses out on the funding. We get the funding, but the DHB doesn't see it. And then they take it off the Care Plus as well. And so, in our current system, that's about $800,000, nearly $1 million, about $1 million. And the DHB is very aware of this, and we're probably the most heroic users of Hoser Health Card in the country. Most other DHBs have got this sussed and have already dropped their Hoser Health Cards down. For every dollar less that we use on Hoser Health Cards, we will get that dollar back in Care Plus funding, plus it doesn't get debited against the national formula for Canterbury. The DHB has promised that they will identify that money that was previously being lost to them and was coming to us, and that will remain in the system, so that won't get siphoned off and spent on something else. And so essentially, if we get rid of all Hoser Health Cards, we get about $1 million more. So all that money will not go into the administration of the system, it will not go into more HIPs, it will come directly out into the funding pool, which is then divided up for delivery of this service. So, can you carry on using Hoser Health Cards? And the answer is yes. Hoser Health Cards are a national right, and we can't tell you not to do it. But from the previous side, you can sort of see that from a system-wide point of view, it's kind of unwise for us to be using Hoser Health Card as a funding mechanism. So what we are proposing is that, and those of you working at the coalface will know that you'll have the odd patient who will come in the system carrying on having their Hoser Health Card and so on and so on. We're not going to want you to be having arguments with them. The people who insist, you just fill in the forms and away they go. So we think that our current rate, which is Pegasus, is somewhere around 3.5%, whereas another PHO in Christchurch is less than 0.1%. So there's a very big variation in how we behave already. So if we got down to 0.1 or 0.2%, then we've got most of the benefit we think we had. So the odd person on Hoser Health Card, don't feel like you're being told you can't. You can. It's just we'd like you to understand the logic of the system. What will happen to your funding? Well, the example I give is if your monthly amount for your practice was $10,000 and you're getting $1,000 in Hoser Health Card, then you'll get $9,000 because you're getting the other $1,000 by Hoser Health Card. And so it'll be exactly a dollar for a dollar, so there's no penalty. You just have to fill in a whole lot of forms and go through all those unpleasant hoops to get Hoser Health Card, or we will give you the exact amount of dollars in a monthly check the other way. So practitioners can continue to use Hoser Health Card if you wish to. We think that would be unwise, but you have the right to do so. So what's going to be the benefits? We think that patients are going to have better coordinated care. We'd like to free up our practice resource time, so doctors, nurses and then administrators to be able to get on and do more clever stuff for our patients rather than having to remember to go in and claim their funds on the portals. We think that you're best at targeting the need to the patients, and hence the very high trust, low bureaucracy system, which is take the funds, use it wisely, and get it to the right people. The funding is available to all populations. So I mentioned before that it was weighted away from children and towards the elderly, but you have the right to deliver the services to any age group that you think is appropriate. So you do not have to target specifically. Sorry. We won't tell you who to target. It's entirely up to your practice team as to who you target. Replacing Hoser Health Card will impact a small number of people, and there's been some modelling done on that. People who get a Hoser Health Card get exactly the same benefit from the health system as people carrying a community services card. Most people on Hoser Health Card are eligible for a community services card. So those people who are eligible, they get the same benefit, which is reduction of reduction of cost of 24-hour surgery or out-of-hours facility, which is the main one. There's only a small number of people, and it's less than 1,000, who are on a Hoser Health Card who may not be eligible for a community services card. And so those people, we would ask you on a case-by-case basis to think about their situation and decide how you want to deal with that. If you come back to where we started, the intention of the service is to reduce unplanned care and improve coordinated care, which means that us, our teams, are seeing these people and providing their care. So to have in place a benefit which encourages or enables them to go to out-of-hours care seems like a bit of a paradox. And so my argument is, well, if you've got someone who falls into that category, take the $15 out of your till and give it to them if you want to. There's nothing to stop you doing that. If they are suffering because they're having a $15 more cost of the 24-hour surgery, then you can deal with that on a case-by-case basis. Or you can give them a Hazy Health card. But we have to be honest that there are a small number of people who will be disadvantaged. The system will be much more advantaged. So based on the modelling, the majority of practices will get additional funding compared to where they are getting at the moment. Now, just to detailing that clearly, the PHOs have been allocating everyone Care Plus, and for those practices who don't use Care Plus, the unused allocations are then reallocated to other practices who use a lot of Care Plus. So practices who we're describing as the heroic users of Care Plus, and well done, thank you for doing that. If you're a heroic user, you may find that your total funding will go down. But everyone will get more than what their ministry allocated amount will be. So if we went back and said, nope, you're going to get exactly what is fair and reasonable, then everyone will get more than that. Plus also there's another nearly $1 million coming into the system. Certainly there's going to be less bureaucracy, so there's going to be a whole lot less in the way of workflow and that sort of stuff at front desks and in our consulting rooms. And then the bottom point is just that we're encouraging people sort of from now to start reducing the use of Hazy Healthcare. How are we going to evaluate it? Well, as I've said through the program, we're not entirely sure what the correct solution is going to be. We know what we want. We want to get reduce unplanned care, better coordinated care for our populations. What are the tools that you guys will employ to do that? We're not entirely sure. We've got some ideas. And so what we're going to do is we're treating this as a kind of a 3-year pilot. And so we're asking you to give us a narrative report about what you're doing. It doesn't need to be highly detailed, but we would encourage, we're seeking feedback. So we're keen for someone in the practice to actually give us a bit of information about how you're using this. The health system will provide you with some reports, and so the reports that we're currently looking at doing was sort of thing that actually the health system does see, but we don't as practices. So we'll give you some information about where you sit on your use of unplanned care services. So how many of my patients turn up out of hours or in hours at ED? How many end up at the 24-hour surgery and the other out-of-hours providers? How much am I using outpatient appointments, and how many of my patients end up in hospital with what is known as ambulatory sensitive hospital admissions, which is considered by much of the health system to be unnecessary admissions to hospital for medical reasons. So we'll start getting that information back as practice teams and benchmarking ourselves against other practices that are of a similar nature or a similar demographic. Now that's not going to be punitive. We're not going to say, oh my God, you're sitting in the top 5% use of ED, therefore we're going to restrict your money. We'll be asking practices, just as you have for the last 20 years with Pegasus, start having a look at your utilisation, start having a look at what you do, and then start reading some of the blogs and newsletters about what other practices are doing and how other people are actually making a difference with this funding. So here's the bottom, we'll ongoing monitor the use of Hazy Health Card. It's not meant to be punitive, but if practices are still heroically using Hazy Health Card, we'll probably pop out and ask them why. But the answer can be, well, that's what we want to do, and so we're not going to be punitive. It would seem to us illogical to continue using them in large volume. And of course, it's the health system that ends up losing out if people continue doing that. But as I keep saying, we'll all have a small number of people who will insist on still having their little card because they've had one for the last 5 years and they want to keep going. When's it going to happen? Well, 1 October, so that gives you a few months, 5 to 4 months to start working within your practice teams and thinking about how you might utilise this, this resource. And don't forget, you're doing all this already. So on 1 October, you can pretty much carry on doing what you're doing. It's just that you're not going to have to call it down dollar by dollar. So you don't have to change anything that you're doing. So all the things that you've currently set up, you can carry on doing if you want to. What we're doing is trying to be flexible so that we get some innovation going on. So we'll send you some indicative funding just as soon as possible. So in June, we're hoping to give you a kind of a heads up about the kind of quantum we're talking about. And then in August, we're going to give you a much more detailed idea of how much funds are going to flow. But my understanding is that the June should be a close ballpark. So you'll get an idea of how much money will be coming that way. It'll be coming as a monthly bulk payment, as I've made a couple of times. Your PHO will tell you when to submit your final claims, but my understanding is that we're trying to make this pretty much a cliff edge. So anything's not claimed on 1 October is part of the old system stops. And all of the unspent funding available through the 3 PHOs will be tipped into the front end of the new system, which will then be allocated out to frontline provision of care. HOSA health cards, the bottom statement just is obvious, so obviously they will expire when they expire, and then it's up to you how you manage your patient expectation around further HOSA health card. Certainly in my practice, most patients don't know anything about HOSA health card, they're a bit surprised by it. It's us who's been driving it rather than the patients, but there will be some people who that's not the case for. I think that's everything. There's plenty of information available. You can go to any of these places, and the Canterbury Clinical Network will be continuing to provide information about this as running the program. And at one of the meeting we had in Ashburton, there was a suggestion that we run a sort of like a blog of good ideas, so that there'll be probably a page up on there where people sort of talking about the kind of innovations that they're doing and so on, which I think is a sensible thing to do. That's all I wanted to say. But you'll have some questions and so on about what we're doing and why. So